is clear marginalisation from broader society. So the key issue of the question of services and systems that might be relevant in a humanitarian setting are also relevant here, where the capacity for Burmese migrants to access culturally supportive and relevant mental health services and appropriate services is basically zero. So there are aspects of this situation that could be perceived as similar to a humanitarian setting, and so my argument is that this divide between MHPSS and this broader field is not as realistic or simple as we might see, and that there's interconnections that can be drawn out and learnings from both fields that could influence the other. So this is not a population for whom MHPSS in its more classic definition is really considered as relevant. But there are some things that can be learnt from this setting that could also, I think, influence usefully the field of MHPSS. And one example from this research project, for example, is that the issue of building research capacity of local organisations. So in a research study where there is no clear intervention, I think that the intervention that should be considered and should be a very central part of the research is the training and skills building of local staff, ongoing capacity building and building the capacity of local organisations to conduct their own research projects. So not seeing this as a means to an end to collecting the data needed for the project, but seeing this really as central to the research activity. And that's something that's not usually done in a humanitarian context because of some of the uncertainty and urgency, but there are different ways in which this was done for this activity which would be feasible in any humanitarian setting. You can give people recognition of the training that they went through in order to be an interviewer or research assistant, and that can then help them access new training or new opportunities. You can continue to work with the same interviewers and translators and researchers throughout a longer project in order to build that capacity and awareness of research. And I've really seen that with the organisation we've worked with, in that people who have conducted qualitative interviews, who've now conducted surveys, who understand something about sampling, are now really able to go on and bring those skills to other organisations and be able to firstly have their own livelihoods affected in that way, and hopefully really transmit some of the research capacity to that setting. And what I want to really start thinking through in my own work, and just to finish up here, is that there are clearly issues here that are relevant and have been identified in the field of global mental health that I think really draw out these interconnections. So of the Lancet Global Mental Health papers in 2011, 2 of those 6 papers were very relevant to the issues here. So the one on human resources and capacity building, and one on poverty and mental disorders. So it's clear that many of the themes in the field of global mental health are very relevant in humanitarian settings, but they're still seen as quite separate and distinct. So just to finish up here with conclusions, and I'd be really interested to hear any thoughts or questions or ideas, but basically I do think that there are increasing opportunities to combine evidence-based practice and field work, and I've given a couple of those activities, and there are exciting things happening. There's a monitoring and evaluation task force in the IAC reference group, so there's people who are being brought into those field-based communities, field-based settings, who are experts in measurement and sampling and those kind of questions, and there's really increased communication that's happening. What I think there needs to be more of is a really creative search for methods and approaches, and so everyone says how hard it is to evaluate a psychosocial activity, but instead of really staying with that and then continuing to focus on clinical interventions for evaluation, we need to really think through what kind of methods and approaches could be used, potentially drawing on completely different fields outside of the field of public health to bring in here. And what this really needs to be in many ways is the two-way exchange. So it's not just on the academic community to respond to field workers' needs, but it's also on practitioners to adopt research. But what I would really say here is that there really needs to be structures and systems set up in order to facilitate this. So it's not easy where, for academics, the incentives that are set up are that dissemination through a high-quality peer-reviewed journal is certainly the incentive that operates for people career-wise. Dissemination to community-based organisations and making sure your research gets to the field is very important, but there's not necessarily the same structural incentives for that. So I think what needs to be done in that sense is to really start thinking through funding structures and incentives to facilitate this two-way exchange of research and evidence. And I'll just leave it there and be really interested to take questions or
Sarah, you can go ahead and take questions.
Okay, yeah, anyone.
We have about 10 minutes.
Okay.
Well, I have a few demos. So my stomach start, and you see which one you want to address.
Does someone want to add, or I can also just address those questions first off? Okay, so I'll go through those. So rapid qualitative, I didn't go in depth into any of the methodologies, but that's basically, it was about a 3-week study. So the first step is using free listing, and that was using a convenience approach in the convenience sample in the camp of children and caregivers, and asking very basic questions. What are the main problems children and adolescents face in this camp? What are the problems that adults have that influence children, and what are children's coping approaches or strengths and supports in the camp? And so getting really a list from this group of around 40 people, and then analysing that list actually as a group with all the research assistants, so in the Karenni language, and then identifying the most commonly listed problems and the problems that were most linked to mental health and psychosocial issues, and identifying key informants to go into those issues further. So that's a methodology that's been used in a number of different activities from the Applied Mental Health Research Group at Johns Hopkins University, and it's used really as a basis for developing instruments, developing then interventions, and being able to ground the research in this activity. It is rapid, and it is something that's, that can certainly be critiqued from, anthropologists who say or a more ethnographic approach, which really requires more in-depth understanding of the dynamics of a camp, but it's really a way just to get quite a quick snapshot of what some of the most commonly listed activities are, and then to really try and delve into those with key informants in the camp. So that was the first. I hope that addressed that. I mean, I think that documentation of interventions is done in the way that you were saying in these long reports, and that there is a difficulty in translating and communicating interventions in this field. So even when you create a manual from some of these types of activities, it's this really big, thick manual that has 8 long chapters, and even when it's translated into local language, is just very hard to access. So I think what you're saying is it's not only just translation of research, but if you do identify effective interventions, how do you then try and disseminate those? And I think that's, looking at child-friendly spaces, that is something why that's so much easier and so much more implementable in a lot of ways. There are just these step-by-step ways of doing it. and I think the field does need to think through ways of better communicating these more complex interventions. But I'm certainly not an expert on that, and I can't think, of ways to really address that. Yeah, exactly. Right. And the third thing around suicide prevention is interesting because it's something that is very rarely mentioned in this field, and I think where it is mentioned, it's in a research context where if you ask a question about suicide, there has to be a safety plan, and we did have, we used the Hopkins symptoms checklist, so we did have, question, have you ever thought this? If so, there's a safety plan, and we referred someone if they endorsed that item, but actual suicide prevention activities, I think, are very few and far between. I'm not as familiar with it, but there is some research that just came out of refugee camps in Nepal, because they did see a spike in suicide in the camps and thought that was associated with resettlement plans, and that this issue of resettlement had created immense uncertainty and issues in the camp, and they did see a spike in suicide. So there was research on really the prevalence of it, but not really on activities to prevent it. So, yeah.
There's some research now from out of Japan.
Which is something that is very neglected in research and programming, and also of alcohol and substance abuse, which again, the camp that we were working in used to have this acronym is DARE, and it's an activity that used to be in America, in high schools in America. I forget what it was called, but it was completely discredited in America. But they had these activities in the camp that were around alcohol and substance use interventions for adolescents that didn't seem to be especially effective. But a lot of people in the camp, once that was actually been axed, said, we really want that back because we know it's a problem. We want at least some activity that's doing something to do with it, even if it's not working. So, yeah.
I came late, so I'm sorry if you did address this, but you're talking about how there needs to be like a two-way exchange between researchers and practitioners, and you mentioned that in MASOP, the services for those migrant communities really aren't there. So, I mean, what are your thoughts about going into settings like this where the services are basically non-existent and doing research on these issues and potentially raising these issues for people who then, once you're gone, have no way of sort of accessing? I mean, obviously you need to provide, a sort of needs assessment to say, hey, these services need to be here, but if the services aren't there and there's research going on and there's no ongoing support, I mean, how can you sort of how do you navigate that as a researcher if you know that once you're gone, there's nothing to sort of support the participants?
That's a good point. I mean, it's a point that has a lot of different perspectives in the field. So this team of researchers at Johns Hopkins have the motto, no survey without service. So they won't do a survey unless they have the funding and support, and they know that once they've done the survey, they're able to do an activity afterwards. So that's a model that potentially limits the amount of surveys, but addresses that question that you're talking about. And in MASOT, so my study didn't have an intervention component, but there had just been a study that was a randomised control trial that developed a clinical sort of mental health intervention for migrants there. So there was that activity. It was almost quite coincidence that both those projects were at the same time, so I shouldn't use that as a justification. But I mean, I think it's a tension, because I think in some contexts, I mean, especially now, there's a lot of thinking around mental health issues and the things that are coming up in Burma right now with opening up and more funding for the health systems there. I think if you don't have good, relevant, recent data, and there's really a lack of that in Burma, and particularly in the very conflict-affected areas of Burma, that it's hard to make a case to a government and at a health systems level that they do need to invest in that. And so it's sort of a tension, because I do think you can raise expectations and you can publish a paper that says, it's a prevalence of 40%, we have to do something, and no one picks that up. But at the same time, without even bringing that to the fore, you have the danger of mental health and that always falling to the side when you have health system development and sort of always being shunted to, okay, eventually when we've set X, Y and Z up, we'll put that in. But I think what, again, sort of identifying that these first research studies in this field were just prevalence studies, and they did just go into Thai refugee camps and say, what is the prevalence of PTSD? And we would probably now say that's very ethically dubious, but that really did generate a lot more activity around the field. Right now, that might not be the best approach, and that might not be what should be happening, and that's why I think we need to reframe these kind of studies as needs assessments that are linked to interventions and activities. Yeah.
Well, please join me in thanking Sarah for being here.